Good morning. I'm on this call myself and my colleagues who work in primary care who will be available to support with questions and answers afterwards. I'm Sharon Davies, Service Lead for Occupational Therapy in Pembrokeshire, but also on the call are Karen Holloway, Jane Moran, Claire Raymond and Nicki Price, who are our primary care occupational therapists in Pembrokeshire. So to start, we recognise there's a pressing need to transform the healthcare system, and the way in which we plan to manage and address people's needs is a key component in any approach which wants to prioritise prevention and hopes to address some of the preventable healthcare needs that transfer to secondary care. Traditionally, people have accessed occupational therapy at a point of crisis, and we believe that occupational therapy has a significant part to play in delivering a cohesive and integrated primary and community care service by focusing on prevention, proactive care and self-management. And our model involves embedding occupational therapy within general practice. So there's a focus on prevention in a number of key strategic documents and legislation, such as Healthier Wales, Social Services and Wellbeing Act and Wellbeing of Future Generations Act. And there's a constant call for bold new models of seamless health and social care across local and regional level. We believe that our work supports both the vision of a transformation model for Wales and primary care model for Wales, which also asks for seamless working in health boards and with partners. Occupational therapists are the only AHP educated at a pre-registration level in physical and psychological mental health. We have a long history of working within and across organisational boundaries, including housing, employment, third sector, and supporting a personalised care approach. We are an AHP that's fit for primary care. We're a good fit with what's happening there. We've expertise in prevention, early intervention, self-management, empowering and enabling people to achieve maximum functional independence, health and recovery, and doing the things that matter to them. So what did we do? Well, we got excited at the first joining of Bevan. We joined Bevan because we wanted to help evaluate what we're actually already started doing and trying to build that into monitoring, evaluating. We had some transformational funding. We needed to look and see how we were affecting change. So in our workshop day, we plan to continue to roll out our work that had begun in South Pembrokeshire cluster. We'd had some pace setter funding with a Brave GP practice that had taken in 1 OT to test embedding, and that was followed in 2016. They saw the benefits and expenditure across South cluster in Pembrokeshire. And the more involved that GPs became with us, the more they became aware of our specific skill set. Our occupational therapists are often thought of as the gatekeepers and providers of equipment, and our colleagues in general practice began to understand our skill set around living skills, self-care, work function, anxiety and fatigue management, and it was really helping them with what they were doing with their population of patients. So again, with the transformation funding, we wanted to transform Pembrokeshire, and as I say, first Pembrokeshire and then the world. So we recruited extra OTs for the north of Pembrokeshire. The workshop day, on the back of involvement with Bevan, we started to speak with our research and evaluation people. With finance, we invited GPs along to give an outline of their needs and their demographic. We engaged with stakeholders and partners in health and social care. We visited the clusters themselves and engaged with GPs a bit more. And really we planned also to roll out a vocational occupational therapy involvement as well. Part of what we've done in Pembrokeshire, we were privileged to host a project with the Royal College OT and Health and Work Unit. And the project around vocational OT was designed to help people with mental health and MSK conditions to stay in employment. It involved using the AHP Health and Work Report and understand the root cause of problems and facilitate change through cognitive reframing, coaching, validating and advising and negotiating with people and encouraging and providing feedback to the persons, to their work environment, making adjustments to lifestyles, tasks, timings or duties. So we wanted to really build on that project and expand that in Pembrokeshire as well. So we were excited, we had extra staff, we had transformational funding, we had Bevan, and we were about to get started in February, but then COVID. And our website, I won't go into all our aims and objectives, but our website on Bevan will tell you a little bit more about what our aims were and what we thought we would be evaluating. But with COVID, and this slides back the transformation journey and beginning in fear and ending up in a place of joy, hopefully. And that's a little bit what we felt like in our transformation involvement, but also with COVID. Initially, we were disappointed and distressed because we weren't able to start the project that we wanted to and that we'd put a lot of hard work into already. Staff had been deployed elsewhere, but COVID actually became an opportunity. And the last year has meant going through, I'm still going through sort of that process of change. But what it found as an OT is that often we're able to adapt really quickly to newly presented challenges. And we thought the work that we'd done had stopped, but actually when we looked at what we'd achieved, we'd actually done quite a lot. And COVID had presented challenges around needing to support people to remain at home. And we had to use a red, amber, green rating to see people who were in the red zone, but it actually became our opportunity to measure our input at admission prevention and reducing immediate risk of harm, manual handling, care support, breakdown. It wasn't specifically proactive, which is where we're aiming at, proactive, preventative, but that's become part of our evaluation. We also looked at the impact of COVID led to remote working. We wanted to be embedded in GP practices, but actually we had to develop another way of establishing team working, take the opportunities to promote OT. And what that led to was framing our communication, enabling collaboration with GP surgeries through virtual contact, using technology, being involved in multi-professional meetings through Attend Anywhere. We managed to get remote access to patient care records, which had been an issue for a number of years. Now we can work from home and still contact and record what our input is. We use an easy reference poster for practices so they wouldn't forget who we are. It's got all the staff's faces and contact numbers on it. We also centralised our systems so that it was a simpler allocation, swifter response, closer to home. We were preventing and planning rehab and providing accessible services across Pembrokeshire. So it actually led to a place where we were able to evaluate our value and impact more than we realised we would be able to. This slide's really sort of a composite of some of the findings that we had. Again, not going into too much detail, there was a lot that we could have bought. For example, we saw 74 people with admission prevention over 28 days. 78 of them were still at home. Of those who went to A&E, they were able to, only 3% remained in hospital. The rest were able to go home because they were all supported by the work we'd done. With the primary care OT's involvement with people where the reason for referral was reduced function, we haven't got feedback from all those people, but 67% of them are reporting early improvements. Through utilising technology and remote working, it's increased our availability and offers alternative solutions to working with people. And what we found is that our capacity increasing means our response times increased. We've got a reduction of 95% reduction in time waiting for an OT to be involved with people. The longest wait has reduced from longest wait has reduced by 87%. So these are really massive reductions in times waiting to be assessed. The team I've got on the call have done a great job in collecting patient stories, which are on our Bevan web page, and it shows the importance for those people regaining their independence. There's a post-COVID story, a self-management and workplace assessment story, and what it does is demonstrate the value and impact for patients and the outcomes for patients alongside value-based healthcare. So what, I guess, is what's the difference that we're making? We concluded that OTs are perfectly placed in primary care as first contact practitioners to reduce caseloads across primary and secondary care settings. It's a prudent approach to healthcare. We have conversations about what matters to people in the right place, the right time. Being embedded in primary care, we're perfectly placed to provide health and wellbeing service that focuses on self-management as part of a continuum provision. We're aware of social prescribing. We can engage as part of that process. Does the person need support to participate in activity? Is the environment right for them? Do they need a group activity? Is social prescribing the right path for that person just now? And recognising the connection between health and mental well-being, occupational as therapists are perfect to begin that conversation, and also work being a therapeutic input itself for some people. Again, in COVID and people's absence from work, working distantly, the impact of all of that and how people are going to get back to working environments. I need to go on to my next slide. We believe we're a strategic fit to everything that's happening, that it's a perfectly flexible and adaptable approach that meets local population needs. There's OT fits into the positive connections in communities, that we're holistic and client-centred, that we understand both social and health aspects. I'm using the Family Jones as part of Howard R's presentation of how we're answering the Healthier Wales call, and we're preparing to play an essential role in the post-COVID work. There's a rehabilitation framework for recovery for people and populations who are affected directly by COVID. The debilitating effects of COVID are broad-ranging, commonly including fatigue, pain, cognitive difficulties, breathing, and they can last for weeks or months and may severely impede an individual's ability to work. And this is a huge issue for health and social care as major employers whose workforce have been at the front of COVID, and returning to work is something that we can help people with, as well as the population group who are isolated and shielding. So how we manage to address needs at primary care level is a key component in any approach. And again, we just believe that occupational therapy has a significant role to play in delivering that. And I'd refer you back to our webpage in terms of some value and impact for individuals, and to the team on the call for the impact it's had on them working within that, and hoping that what we're doing will influence the transformation agenda as well. Thank you.